behalf of the Patient Safety Authority, I would like to welcome you to this webinar titled Perioperative Pain Management, emphasizing the role of multimodal analgesia. My name is Kelly Gibson, and I will be your moderator for this program. Now I'd like to introduce our speakers for the webinar. Dr. Katarina Frank is a consultant with Alosa Health. Dr. Frank is experienced as a physician educator and as a drug and violence prevention educator. She has worked as an anesthesiologist and public health physician in Europe and as an anatomy and physiology professor and public health educator in the US. Dr. Christopher Worsham is a health services researcher, pulmonologist, and critical care physician at Massachusetts General Hospital and Harvard Medical School. His research focuses on physician and patient behavior, resource utilization, and healthcare policy. Dr. Frank, I will now turn the program over to you.
Thank you, Kelly. And welcome to our today's webinar. When it comes to disclosures, neither me or Dr. Worsham have anything to disclose. When it comes to topic objectives for today's presentation, these are: understand the epidemiology of opioid prescribing after surgical procedures, review the current recommendations for managing pain, discuss components of a multimodal pain management plan, and describe strategies to reduce risks of opioids. I will start the presentation with a few slides regarding Alosa Health and academic detailing. Alosa Health is a nonprofit organization associated with Harvard Medical School and a national leader in development of programs that provide healthcare professionals with unbiased, non-commercial information with the purpose to improve patient outcomes. Academic detailing is our educational outreach. It is a way to provide clinicians with relevant, up-to-date information in an interactive setting, preferably in one-on-one approach or in little groups. Academic detailers are providing this service. They are clinically trained and meet with providers and staff in their offices, where they go together through evidence-based programs designed by the clinical team in Alosa Health. The service is for providers free, and detailers also supply complementary materials for providers and often also for patients. This is our clinical team led by Dr. Jerry Avorn, who is the founder of the Alosa Health organization. Dr. Avorn is a chief clinical consultant, professor of medicine at Harvard Medical School, chief emeritus of the Division of Pharmacoepidemiology and Pharmacoeconomics. Dr. Ben Rome is a primary care clinician and Brigham and Women's Hospital, instructor in medicine at Harvard Medical School, and researcher. Dr. Will Feldman is a pulmonologist and intensive care clinician. Both Drs. Feldman and Rome advise multiple Alosa modules. The role of the clinical team is extensive and consists of rigorous development and reviews of materials for providers and patients, academic detailers, training and support, real-time updates to material, arrangement of the CME credits for providers and nursing staff through the Harvard Medical School, and other responsibilities as well. Dr. Avorn determined as his third law that good information doesn't disseminate itself. Why is that? First of all, the clinicians don't have time to get current evidence-based information, since there is hardly time to go over hundreds of pages of new research articles and documents. The next issue is the fact that promotional messages often drive the prescribing and procedures towards the costliest choices. Another reason for not optimal prescribing is that physicians have, unfortunately, only partial information quite often. I should also mention that pay-for-performance evaluation programs require improvements in clinical management, and the value of the latest evidence-based balance information provided to clinicians has a huge impact. When it comes to components of our academic detailing programs, there are three. First is the process of synthesizing the best, current, non-commercial, unbiased information. In a second step, information is packaged into concise and engaging material. And the third step is delivery of the material to providers by trained educators, detailers, in already mentioned interactive way. Does academic detailing work? Yes, it does work, and works very well. 3 decades of rigorous study confirmed for us that this is a great way to change prescribing habits with goal to improve patients' health and also reduce the cost. The effects of the academic detailing, the valuable evidence-based information we bring to clinicians have positive and consistent effects and results. Now I will turn it over to Dr. Worsham.
Thank you, Dr. Frank. So with everything that Dr. Frank just mentioned in mind, we're going to start diving into the evidence surrounding perioperative pain management. And the goal of what we're going to go through is really to bring you up to speed on the sort of state of the art when it comes to the safest and most effective ways to provide analgesia for patients in the perioperative and primarily post-operative setting. So we're going to kind of look at the big pictures here, go over some of the reasons why we should be reducing opioid use in the post-op setting, talk about the state of the art for modern perioperative pain management, and then go through some interventions that can be, well, some of them are easily done, some of them are a little more challenging, but are worth doing in various parts of the care cycle for patients who go through surgery. So talking about the big picture, particularly when it comes to opioids, which, as we all know, present a number of risks to patients, and generally speaking, getting good pain control is very important, but there are multiple ways of doing that, and opioids can lead to adverse events. So each year, there's about 50 million surgeries performed in the US. 4 out of 5 patients, at least back in 2012, and believe it or not, the data, the national data on this is actually, there hasn't been a big update since then, but still, you know, around 80%, maybe a little less these days, are filling opioid prescriptions following surgery, certainly a majority. And as I'm sure we're all aware, in the past decades, these prescriptions are leading to adverse outcomes for our patients. So those include long-term opioid use disorders, and opioid overdoses, which may be just opioids or maybe opioids in addition to other substances. And if we look at all of these patients who go through surgeries, about 1 in 142 patients are going to have new persistent opioid use. And while that number seems small, if you think about how many patients are moving through, say, an ambulatory surgical center every day, you know, in a given week, it's going to be a decent number of patients who are picking up persistent opioid use. And then opioid overdose, or a new diagnosis of opioid use disorder, is seen in about 1 in 1,000 surgeries. So again, this is not the most common thing in the world, but when we think about how many surgeries are getting done, it's not a trivial number, and it's certainly one that we should be worried about. This is an interesting study that looked at a whole bunch of surgeries. So they took about 641,000 patients who were opioid naive and not had opioids before and went through surgery, and compared them to almost 9 million patients who didn't go through surgery. And the goal was to compare the outcomes of these patients who went through surgery when it comes to opioids to patients who didn't go through surgery, to get a sense of what is the opioid use associated with undergoing surgery. And compared to people who did not have surgery, the ones who did go through surgery did end up using more opioids. I'll go through the details of that. So if we look at these different surgical types, and if you look on the left-hand side with the list of surgeries, we have surgeries that are very minor and oftentimes don't even require pain management at all, such as a cataract surgery, ranging to more painful procedures like a knee replacement at the bottom. Something like a mastectomy can potentially be quite painful, sometimes isn't so painful. But you can see that, you know, all of these surgeries, cholecystectomy can be quite painful sometimes, other times not so painful. You can see that as we go through these different surgical types, with the exception of some surgeries like a laparoscopic appendectomy, which is often a quick surgery, cataract surgery, many of these procedures were associated with significant increased risk of chronic opioid use. And it's worth mentioning that while some of these surgeries, like a hip replacement or a knee replacement, you know, the patients might be at risk for opioid use to begin with because they're painful conditions. Keep in mind that these were opioid naive patients who underwent surgery. And then some of these surgeries, like a appendectomy, cholecystectomy, mastectomy, these are procedures that are not planned in advance. They're sort of randomly timed. And so when patients undergo these procedures and then on the other end up using opioids on a chronic basis, it does lend us to think that these surgeries are causing patients to become chronic opioid users. And I think, you know, anybody with experience in the surgical setting knows that there are groups of patients for whom opioids are fine and they're able to use them safely, groups where maybe it's safe and maybe it's not, and then other groups where you can see that opioids ended up probably causing more harm than good for a given patient. So with that sort of gloomy outlook in mind, we want to move forward thinking about how can we bring down opioid use and how do we prevent some of these adverse outcomes. So the important thing to remember, and we're going to go through the evidence here, but is that opioids can be de-emphasized in the post-operative setting. They are not necessary, or large amounts of them aren't necessary, to adequately control pain in the post-operative setting. And I think many of us on the provider side of things know that, but a lot of patients may not know that. And certainly many people practicing might think that opioids are the end-all be-all of pain management. And there's lots of evidence that we'll go through that really shows that that's not necessarily true. And in very many cases, de-emphasizing or completely eliminating opioids can be quite beneficial. So I think there's a lot of nervousness when it comes to thinking about reducing the amount of opioids that a surgical practice might habitually prescribe to patients, because if you're doing well and having patients whose pain control is adequate using a certain sort of protocol that includes opioids, it might be a bit daunting to think about lowering the amounts of opioids used. But in one state, and that's the state of Michigan, and we'll look at their data on the next slide, when they came out with new opioid prescribing guidelines, it resulted in patients post-operatively getting smaller prescriptions, using less opioids, but most importantly, despite using less opioids, there were no changes in their pain score and no changes in their satisfaction of care. And so if we look here, this on the top, we'll see that over the course of 2017 and 2018, with that vertical dotted line being when there was a change in the guidelines, we can see that there is already a bit of a trend of the size of opioid prescriptions lowering, But when this guideline came out, the size of those prescriptions started to lower a bit more dramatically. And so between the beginning of 2017 and mid-2018, we saw a lowering of the amount of opioids that were prescribed to patients in the post-operative setting. On the bottom plot, if we look at the black line in the middle, again, that's the size of these opioids prescriptions that you can see going down. But if you look up at the top blue line, that's the satisfaction. So over this time, satisfaction with care stayed the same, even though opioid use was going down. And the bottom red line, their pain score, which hovered around a 5 out of, a 1 out of 4, the pain score didn't change either. So we saw a reduction in opioids, but no reduction in satisfaction or pain levels. And if you can remember one thing from what we're talking about today, it is this slide, that reducing the use of opioids does not result in less satisfied patients or worse pain control. So then that begs the question, what are we doing instead? And how do we do better? So the opioid epidemic that we have seen has really forced all of us who deal with patients who are in pain, and that's pretty much any practitioner out there, to rethink about pain management in general, and particularly in the perioperative setting, because it does seem like surgery has been linked to causing these adverse opioid events. So yes, we can reduce opioids by themselves, but how do we, A, adequately control pain if we're using less opioids, and B, how do we present fewer risks to our patients while controlling their pain? And so many of you may have heard of the concept of multimodal analgesia, and that's what we're going to talk about today, but it's really to think about pain control over the entire cycle of care. And by cycle of care, I mean, if we're talking about surgery, we're talking about everything that goes into the preoperative evaluation of patients, everything that happens the day of surgery in the pre-op area, in the OR, in the recovery area, and then what happens when patients go home. And along this whole cycle of care, we have to be thinking about using multimodal analgesia, so multiple different ways to control pain, not just one. In the beginning, we think about assessing patients for the ideal pain management plan. We educate them about what they should be expecting and what pain is and how we treat the pain. There's a lot of considerations on the day of surgery between surgical providers, anesthesiologists, nurses, everyone who's taking care of the patient that day, as far as different modes of analgesia to reduce the need for opioids. And then in the post-operative setting, we really want to make sure that we are tracking responses to treatment and adjusting those treatment plans accordingly, recognizing that if a patient's pain is not controlled, it doesn't necessarily mean that they just need more opioids. It could be that they're having a complication and really need further assessment. We also want to continue that education in the post-operative setting. And then at the very bottom, you'll see I noted this consultation with a pain specialist, which I felt really has to be put in there, because when you have very complicated patients with complicated pictures, perhaps they already have opioid use disorder or are already a chronic opioid user, it can really be beneficial to work with a pain specialist to plan out what's going to happen. One of the reasons I'm nervous to put it down there is because these specialists are often in such short supply. So I think it's really important to use them if you have access to them. If you don't have access to them, advocate for getting access to pain specialists. But I do recognize that not everybody has ready access to a pain specialist. So keep in mind some other reasons beyond sort of protecting patients from the adverse events associated with opioids. There are lots of other reasons to reduce our use of opioids. So let's keep in mind that we don't always give opioids for good reasons. Sometimes we just give them because it's habit. This patient is here for procedure X. Everybody with procedure X gets this prescription sent to the pharmacy, so that's why the patient got it. That's not a good reason to give a patient opioids, and that's the type of behavior we should avoid. There's all kinds of protocols that we come up with that are based really on nothing, or might be sort of based on experience, but are not based in data or evidence, that could actually be putting patients at risk. And then sort of combining these, it's basically when we have a one-size-fits-all approach, and we all know that each of our patients is unique, we are inevitably going to be harming patients for which that one-size-fits-all approach doesn't actually fit all or presents risks to them. And then we should keep in mind that while opioids can cause problems for our patients, they also can cause problems outside of just that patient. So it can cause problems for their families and their entire communities. We have good evidence that once an opioid prescription enters the home, that family, in particular people like adolescents and children, but also other family members, are at risk for opioid events adverse opioid events because an opioid entered the home. And so it's really important when we think about the opioid epidemic, it is not just the patient that is potentially harmed by an opioid that a patient doesn't really need. It can be their family members, and it can be the larger community as well. The other reason we should be reducing opioids is because it actually can help your patients to reduce these opioids. So beyond just avoiding harms, it can help them. We're all aware of the adverse symptoms associated with opioids: nausea, vomiting, constipation. I had taken some oxycodone for a shoulder surgery and stopped taking them despite being recommended that I should, because I just found all of the side effects to be much more unpleasant than the pain I was having in my shoulder. And a lot of patients are the same way. We have patients who run into trouble and end up in the hospital or worse because of these side effects that could just be avoided. Importantly, less opioids means shorter length of stay in a facility, whether that's an ambulatory surgical setting or an inpatient setting, which everybody likes. Patients don't want to be there longer than they need to. We don't want them to be there longer than they need to. And then again, there's that reduced risk of the long-term harm. So both positive things from avoiding opioids, and we're also avoiding the negative things that come with the opioids. A practice can also benefit from this. So reducing peri-op opioids, particularly in conjunction with adding other types of pain management, can lead to improved satisfaction. So if your patients are better controlled because you're using other ways to treat their pain, they might be more satisfied. They're also going to be more satisfied if they're in the facility less. They're going to have fewer side effects. All could lead to better patient satisfaction. We have improved patient safety and reduced adverse events, which we've talked about. And in particular, when it comes to quality metrics, financial incentives, organizations like Medicare pay for performance when it comes to making sure we are using multiple different types of analgesia and not just opioids. So again, coming back to this slide, and we're going to show it a couple times just to reinforce that we need to be considering all of these things in the pre-op, intra-op, and post-operative setting. To really drill down into this, it's really important to think about what are the ways in which patients experience and process pain. And that happens in multiple different areas. And we did borrow this image here from the paper down there by Mariano et al. That does a really nice job of talking about how pain is experienced in the body. So we start down at the orange box there. The source of pain is going to be, the tissue trauma caused by surgery. And there's a number of ways we can relieve that are safer. So we talk about patients who get ice therapy or compression. You can give local anesthetics that don't have a lot of side effects. And then drugs like non-steroidal anti-inflammatories prevent inflammation at the surgical site, which can reduce the pain. Once pain has been generated in the body and we move up to this yellow box here, we transmit that pain signal from wherever we're experiencing pain up to the brain. And we can stop that transmission through things like regional analgesia. So that would be things like nerve blocks, using epidural analgesia instead of general analgesia to stop the transmission of pain signals. And that's where some of the drugs also start to come in. So opioids act in multiple different places. One of them is in the transmission of pain. But then we also have drugs like gabapentin or pregabalin that target the transmission signals of pain so that that pain signal never actually arrives at the brain, or if it does, it arrives in a reduced intensity. And then drugs like ketamine, which is being used more often in the operative setting, and now we're seeing a little bit more use in the post-operative setting, that really prevent transmission of these signals within the body. And then finally, we talk about processing of pain. So the pain signal has arrived at the brain. What does the brain do with it? That's where we experience pain. And for any given patient who receives two different, the same pain signal, depending on how they process it, they might experience it as more or less painful. So when it comes to things like anxiety or confusion, a patient can experience pain more severely, which is why we emphasize education surrounding the pain. Telling patients pain is part of the surgical experience. This is why you're experiencing pain, because your body has been traumatized by surgery. It is normal to experience pain. But then we also have to focus on expectations. Some pain is normal. An excessive amount of pain is something we will treat. But just to feel some degree of pain is normal, and so there doesn't need to be additional anxiety superimposed on that. When it comes to longer term ways to manage this, there are things like cognitive behavioral therapy and some psychological approaches. And then we also have pharmacological approaches. Acetaminophen works in the brain. How exactly it does that, we don't really know. But importantly, we know that acetamin is very, very, very safe and acts in the brain. And then these same drugs that prevent transmission of pain signals in the body will also dampen the receipt of pain signals. And this is why drugs like opioids are so effective at managing pain, because they work in multiple parts of this pain pathway. The problem is, of course, that they come with a lot of adverse events. So our goal is to reduce pain at the source, reduce transmission of pain, and dampen the processing signals of pain to make it experience less pain while putting patients at minimal risk. So there's a lot of details to this that vary from surgery to surgery, but we're going to talk about some of the broader considerations here. So keep in mind that a preoperative assessment really should be to figure out, again, preoperative assessment from a pain standpoint, you want to figure out where might there be challenges in the pain management for this patient. So particularly patients who have pre-existing pain or have pre-existing medication use, patients that may be coming in with opioid tolerance. If they're going to be experiencing additional pain during surgery, they're going to need special considerations, and you're going to want to think strongly about what are the other ways we can control this person's pain so that we don't have to give them excessive amounts of opioids. Medical comorbidities and functional status actually play a lot into how patients might experience pain. If you have trouble moving around, you're going to have trouble shifting your weight after surgery and relieving pain from a certain position. So just keep that in mind, that if a patient may be able to manage their pain by making sure that their family member or neighbor is checking in on them periodically, and that is a solution that doesn't involve any opioids. Patients with psychological conditions, including substance use disorders of any type, we know are at increased risk of challenging pain management and adverse events. So these are the patients that really deserve special attention. Referral to pain specialists in particular is important for this group. Talked a little bit already about managing expectations. When patients have had their expectations set in the preoperative setting, they know what they're getting into, they're more likely to be happy with the surgery on the postoperative side. If they know to expect pain, when they experience pain, they're not going to be as bothered by it. We want to educate them. What type of pain will they experience? Is it sharp? Is it stabbing? Is it burning? How bad is it? How long is it going to last? All of these things the patient should know so that they can psychologically prepare for it and know what is normal and what is abnormal. We also want to emphasize that we want pain to be reduced to a satisfactory or manageable level. We are not necessarily, or frankly, very often, we're not actually looking to eliminate pain altogether. And like I said, the higher risk patients here are the ones who really should be thinking about a pain specialist referral, because they can help along the entire pathway of surgical care. In the postoperative setting, patient and caregiver education is really important because we want to make sure patients have realistic expectations about how their postoperative course is going to go, what is normal, what they should be expecting, what they should be looking out for when it comes to pain. Again, get them to manageable levels, not elimination, and explain to them what is a typical course so that for most patients, their expectations are in line with what will probably happen to them as far as pain. It might be really bad in the first couple of hours. We'll be more aggressive in treating it then, but then it'll start to ease up, and as we get you moving around, your pain will reduce in its severity. Patients really need to know this. So when it comes to multimodal analgesia, what are our other options? So without getting into too many details, because each surgery has so many different considerations, I would encourage you to think about, in the surgical population that you see, which of these make sense. Are there surgeries where a nerve block makes more sense than general anesthesia? Orthopedic procedures that might only involve an extremity are, ones that easily come to mind, where could we just do a nerve block instead of using general anesthesia? The benefit of a nerve block is not only can you operate using a nerve block, but it provides lingering anesthesia during that period of time where the pain is the worst. There are very, very few situations in which acetaminophen is inappropriate, and you should be thinking about using acetaminophen in pretty much every patient, including patients with liver disease. Patients with severe liver disease, you may need to dose adjust, but there is not a single patient in which you should not be considering using acetaminophen as a mode of pain management, because its safety profile is so good and it is effective. NSAIDs have a couple more relative contraindications. If there's particular concern about bleeding, you may need to think about whether NSAIDs make sense, but for a large majority of patients, NSAIDs are also something that you should be thinking about in almost every patient. NSAIDs combined with acetaminophen are particularly powerful together, and again, have a very good safety profile. Steroids in the right setting, that again is focusing on reducing inflammation, and so just stopping pain generation altogether, can be helpful in certain settings. They're also helpful with nausea management. Gabapentin, pregabalin or gabapentinoids certainly also have a role. Really want to think about that when we think that neuropathic pain is a part of this. So if nerves are going to be irritated, or think about it for potentially an amputation, this type of focus on the pain transmission pathway might be particularly useful. And like I said, we should be keeping an eye out on ketamine and its use. They're finding new places where ketamine can be used safely and effectively for patients. Some of that is in its infancy, but it's something we should be keeping an eye on, because it may really help patients avoid some risks of opioids. So really want to think of opioids as a tool on your belt, but really it should be one of the later tools you reach for, because if you try these other methods first and they're still in pain, obviously we need to control excessive pain. Opioids will still be a part of our armament, so to speak, but they shouldn't be the first thing we grab off the shelf. And really, we should think about them being the last thing we grab off the shelf. So is multimodal pain management effective? And this study is really interesting, looking at hip and knee replacements, only a certain type of surgery, but it's looking at sort of multimodal pain management broadly. So looking at 1.5 million hip and knee replacements, they followed patients and looked at, did they have opioids only? That's the blue line. Did they have one additional mode of analgesia? Did they have 2 additional modes of analgesia? Or did they have more than 2 modes of analgesia? And that's in the purple line there. And so we can see in the 10 years from 2006 to 2016, people working in the hip and knee replacement world did increase their uptake of multimodal analgesia. And you can see that by the time we got to 2016, over half of patients were getting at least basically 3 modes of analgesia, which potentially may or may not have included opioids. And that was basically at the expense of opioid only, or just opioid and maybe Tylenol only. All of those trended down. So really moving towards more modes of analgesia over time for both hips and knees. And that's what we see on the left panels there, hips on top, knees on the bottom. If we move over to the right panel, what this is showing us is the size of opioid prescriptions based on which mode of analgesia they use. So over time, we see that, not surprisingly, the people with the purple line on the bottom who are getting 3 or more modes of analgesia have the smallest opioid prescriptions, if they had opioid prescriptions at all. And as we reduce the number of different strategies of multimodal analgesia, the size of the opioid prescription gets bigger and bigger and bigger. The good news here is, over time, even the patients who only got opioids were getting less opioids. But the important takeaway here is that the more modes of analgesia you use, the less opioids your patients are going to need. And there are more benefits than just reducing the amount of opioids. So in the same study, if we look at some of these adverse events that patients could experience, I listed here these side effects from opioids. So we see respiratory side effects like aspiration or respiratory depression, GI side effects, so nausea, vomiting, constipation, GU side effects like urinary retention, nervous system side effects like mental status changes, and then they threw the rest of the complications into another bucket. But what we saw here is, as we move from left to right across this table, we see that if we use one mode in addition to opioids, there might be some reduction in some of these side effects. But when we got to the 2 or more modes of analgesia in addition to opioids, we saw significant reductions in respiratory side effects, the GI, GU side effects, not so much on the CNS side effects, but also these other side effects. We saw a 10% reduction in the size of the opioid prescriptions, a 1.3% reduction in the cost of hospitalizations, although that was not significant, and then a 9.3% reduction in the length of stay. So it's reduced opioid prescription sizes and reduced adverse events for the patients who were getting multiple modes of analgesia. So another takeaway here. The first one, the one I really wanted you to remember, is reducing opioids does not cause problems. And the second take-home point I really want you to take home from this is, each additional mode of analgesia lowers the risk of complications. And that's really important. So the more ways you can manage the pain, the better it's going to be for the patients and that comes with that reduction in opioid use. It's really important to note that these additional modes of analgesia were not associated with more complications, costs, or length of stay, and so that might be a concern if we introduce a nerve block program in our outpatient clinic, if we're referring people to pain specialists, if we're adding on all these things. Isn't that going to cost more? Don't those come with their own risks? Yes, they have costs. Yes, they have risks. But overall, there were no increases in complication, costs, or length of stay. So that's really, really important to remember. This is a big study of orthopedic procedures, so it may not, generalize completely to other types of surgeries. But I think it's important to keep in mind that just because you're adding things to patient care doesn't mean it's posing more risks or creating more costs or lengthening their length of stay. So now I'm going to turn things back over to Dr. Frank to take it from here.
Thank you, Chris. So I will continue. You saw the slide previously, but it is, again, a good slide to be used for the pain management after discharge. As the pain processing, transmission of pain, and sources of pain management were already discussed, and Chris spoke about it, I would like to say that patients often feel after discharge they are on their own. They have medication for a few days, and after that, they feel lost. They don't understand their pains and often think that something wrong is happening. This is the reason why when it comes to acute post-operative pain or pain after discharge, educating of patients is necessary and extremely valuable. Patients also need to be aware of the resources which would affect after discharge, the sources, the transmission, and processing of the pain, which were already mentioned in detail. Patients who have realistic goals do better, and that is why establishing realistic goals is important. The goal should be restoring as much of normal activity as possible, but not necessarily eliminating all the discomfort. Patients need to be realistic about their pains. They should expect the pains, but the knowledge that they have a good prognosis should bring them, or often is bringing, a comfort to their thoughts. Again, if opioids must be used, the talk about the goal is necessary, and prescription should be for a very short time. Some of the conditions can be resolved without any intervention. Study showed that 82% of patients who were unable to work due to acute low back pain returned to work within 30 days. I will repeat again, it is important not to underestimate value of patients' education regarding pain. In the meta-analysis study, patient education for low back pain showed that patients' education increases reassurance more than usual care in short term. Education messaging delivered verbally or as booklets while focusing on the benign nature of their pain is necessary. Telling patients that they have a good prognosis, that exams are providing the evidence that their pain is as expected, has valuable effect. Finding a balance between undertreating and overtreating is the key. Yes, too much pain and suffering will delay the recovery. However, overprescribing, extensive imaging, and unneeded procedures are counterproductive as well. Helping patients to reduce fear, reduce worry, distress, while assuring the patient that their prognosis is good, does the job and leads to success. How many times you learned from patients or friends and family that they didn't really use all the pills prescribed to them after surgery because they just didn't need them? I think Chris used the example of his own. The results from the study involving patients after outpatient orthopedic surgery who had opioid prescribed were that almost half of those patients used fewer than 5 pills from average 30 dispensed. So 2 out of 5 adults were prescribed an opioid in a recent year, and 1 in 5 shared their medication with others. So more than half of the patients are expected to have leftover medication, and that is what leads to the final number. 54% of adults who misuse opioids are receiving them from friends and family. I think this just makes a perfect sense now when I say that unused pills increase the risk of addiction and overdose death in our population. Note the combination of NSAIDs and acetaminophen, which was already mentioned, but here is the randomized double-blind study. Ibuprofen and acetaminophen combination was just as effective as opioids for musculoskeletal acute pain and without the opioids risk for patients and, of course, the diversion possibilities. NSAIDs are the most effective treatment for acute low back pain. Adding opioid or adding muscle relaxant to naproxen to treat acute low back pain was no better than naproxen alone when it comes to the pain reduction. So what is the best evidence-based approach to acute pain? This table is summarization of multimodal analgesia consisting of combination of pharmacologic and non-pharmacologic treatments together. These evidence-based approaches are represented with these markings. Green circle is a favorable option. Yellow circle is a potentially favorable option. Red circle, unfavorable option. Empty circle, neutral. And circle with the line across means that we don't have studies for this option. Tables like this are part of our ANEDs or our booklets, which we deliver to providers. To review a final approach description, based on presented and existing evidence, we can declare that multimodal approach is the best approach. I think you heard enough of the information for, proof of the statement. Combining drug and non-drug options, using NSAIDs, acetaminophen, and providing a patient's education with portraying realistic goals will lead to improved function, reduced suffering, and minimal side effects. If opioid must be used, keep on your mind the information already shared. It is important to prescribe for short course and continue with non-opioid treatments. Due to twofold increase in overdose death with opioid benzodiazepines combination, avoid this combination. Also avoid long-acting or extended-release opioids. Remember that the term abuse deterrent doesn't mean that opioid is not addictive. It just means it is harder to process it into injectable form. And to close the acute pain multimodal, I would like to remind you to always watch for side effects in patients who had opioids prescribed. And I will finish this presentation returning to some final information regarding our organization, Alosa Health, regarding Alosa Health, modules, funders, and challenges. On the slide, you can see other available modules from Alosa, which provide clinicians with evidence-based information regarding diagnosing, treatment, and approaches. Some of our modules also come with information regarding billing, and all come with CME credits for providers and nursing staff. The material we have can be delivered in physical form or digital, and often includes material for patients. The service we provide is for clinicians and staff free, and that is due to our multiple funders, which some of them are supporting our work for many years. In Pennsylvania, our funders are Department of Health, Pennsylvania Department of Aging, Department of Health, Allegheny County, and Aetna CVS insurance company. And before I will completely finish, a few words about our challenges. You already have the idea about what we are doing and how we are doing it. However, so we offer unbiased and evidence-based information. We also have a few small challenges. The first one on my slide are the gatekeepers. With the changes in phone systems and not being able to speak with other personnel in the office and receptionists, we get miscategorized sometimes when we try to set up meetings with providers. The biggest misunderstanding is confusing us with the pharmaceutical reps, which is also the second line on my slide. As much as I like this on one side, because from my practice I remember they were always very good looking, it is sometimes a little challenging to move across the idea that we are not reps. We are educators with unbiased information. We don't want money. All what we ask for is a few minutes of provider's time. The third line also goes hand in hand with the rep situation, since some of the healthcare systems have a strict policy against the visits with biased commercial information. That is not us. Our evidence-based education is in no way same or similar. And of course, the last is the time issue. Providers are working hard, and we totally understand this. Many of us were on the other side, and we know what a day in medical office is like. What I want to say here is that we always appreciate the time that a provider gives us. We are very flexible, and we use it very efficiently. If it is 20 minutes during lunch or 3 minutes between patients' visits, there is always a benefit for provider, which translates into patient care. To be very honest, it is very rewarding for the detailer to see how the providers who get familiar with our work become welcoming, interested, supportive, and they use the information we presented. After all, by recognizing our work, they know that a few minutes with us is saving them many hours of self-study and information research. Even with few little challenges, we see every day that we are making a significant difference. Our work is important and appreciated. We are part of the care improvement of patients, and that is the main idea behind everything we do in Alosa Health. Thank you for your attention.
Thank you, Dr. Frank and Dr. Worsham. This concludes the slide presentation portion of our program. Now we would like to begin our question and answer period. If you have questions, please type them in the Q&A box found at the bottom of your screen. Please click on the 3 dots, then click Q&A to open the Q&A panel and direct your questions to all panelists, and we will try to answer as many questions as we can. Dr. Frank, I think the first thing would go to you, kind of in summary there, what you were talking about. What does Alosa Health bring to my practice or my colleagues?
Well, we will bring you information based on evidence-based studies. We deliver engaging material, which is easy to use, and often it is a good way to start discussion with patient as well and show it to them as a part of telling your patient why you are choosing certain option for their treatment. We will save provider time by delivering in a few minutes material which would take hours upon hours to search in JAMA, New England Journals, and others. We are available to answer questions and discuss particular patients' cases or issues. We are service, which quite often I hear that it is too good to be true. Providers, when they meet us first time, are suspecting that the true reason will come up at the end in a form of asking for something. Well, no. All we take is a few minutes and deliver info well worth it. I hope I answered the question.
And anybody on the call, are they able to email you directly at these email addresses?
Yes, those are direct email addresses, and we would be happy. I will be happy to answer any questions or requests from the audience.
Thank you, Dr. Frank. It looks like we're getting a few questions in, and we'll just have to move along rather quickly, just watching the time here. The first one is how to use NSAID plus Tylenol in elderly patients with renal insufficiency, especially during NPO status.
I can answer that one. Yeah, this is a really good question. I think, NSAIDs are potentially pose some risk, like you said, in patients with renal insufficiency. Really, we want to avoid NSAIDs in patients who have sort of severe CKD. It's sometimes, depending on the patient situation, if you can easily get in touch with the patient's nephrologist about the risks and benefits of NSAIDs, it's worth having that conversation. Otherwise, patients with sort of minimal renal insufficiency, maybe their creatinine's a little bit high, but they don't have large amounts of renal insufficiency, really need to ask, okay, this is an elderly patient, the risk of opioids are quite high. How does the risk of opioids compare to the risk of NSAIDs in this patient? It may be that you come to the conclusion that you still really don't want that patient to have NSAIDs. But I think a take-home from the story of NSAIDs with Tylenol is it's worth thinking about the risks and benefits of NSAIDs even in patients with some of these relative contraindications, if it means you can reduce opioids in a patient who might be at particularly high risk.
Thank you. The next question, Dr. Worsham, might be for you as well. What is manageable level of pain? I have one surgeon who does not like to use blocks, and the patient's pain level is much higher than that of other surgeons. The surgeon educates his patients on pain prior, but as PACU nurses, we always try to get these patients to a lower threshold pain level.
Yeah, I mean, manageable obviously is, that's not a particularly concrete term, and it's going to vary from patient to patient. You might have a patient who really doesn't mind experiencing pain if it means avoiding some of the side effects of like a morphine or Dilaudid, whereas you have other patients who really don't want anything above sort of trivial amounts of pain, and that's where that expectation management comes in, where you say, all right, well, pain is part of the experience. You're going to experience some, but we can take the edge off to the point where it becomes maybe more of a background issue for you than something that's in the foreground. So, I think for that patient, and I recognize that you may be, if you're working in the PACU setting, you may have nothing to do with what's going on in the preoperative setting. But that's a situation where if a patient's, tolerance of pain or which they value more aggressive pain control versus less opioids, that's a discussion that needs to be had in the preoperative setting. And maybe that's the patient for whom a nerve block is going to be more appropriate. And if one physician has more or less comfort with that, then maybe they should think about having surgery with the person who does do the nerve block.
Thank you for that response. We have time for one more question. If anybody has anything, please feel free to type it into Q&A. I would just like to say that personally, I was speaking with somebody within the past week who underwent arm surgery, and you can tell that there was clear education to this individual and their significant other about the expectations of pain management, the fact that they did have a block and that would kind of keep them comfortable for a period of time after surgery, the fact that the prescription for opioids was decreased and the supply was a different level based on some of these issues with the opioids and trying to use different modalities. So it sounds like some of that messaging is really getting through and out there to our patients and family.
So, sorry, Kelly, if I can interrupt, I received on a chat a question. What is the best way to make health system aware of Alosa Health? I am not sure that our system is aware of this service. The best way is we're trying to figure out this as well, and having a presentations would definitely is one of the way how we're trying to basically let the world know about our services. For those who are interested, our website, to contact us through our website is real easy. To contact me personally through an email, that's an easy. But however, we would like the systems to be aware of our service. That is you know, big thing where we're trying to let our services known through articles, through meetings, through presentations, and definitely it is one of the points of work which we want to do. We want the systems to be aware. We would like them to contact us, and we would like them to accept our services. Thank you for the question.
Thank you, Dr. Frank. And just quite simply, what is the expense associated with your services?
As I mentioned in a presentation, we have funders, multiple funders. I mentioned a few of those for Pennsylvania. And the funders are the ones who are supporting our services financially. When it comes to targeted providers, we provide our services free and, you know, based on their time, based on their need. But we are financially supported by multiple grants. So there is no expense for the providers and clinicians.
Thank you, Dr. Frank, and thank you, Dr. Worsham, for all this wonderful information. I want to thank everyone again for joining us today. If you experienced any issues accessing the evaluation and or certificate of continuing education, please feel free to contact or direct any inquiries to Shelley Meixel at shmixell@pa.gov. And again, if you need any contact information for our webinar presenters, please let us know. This concludes our webinar. Thank you.